Good evening. Am I audible and visible? Good evening. If I'm audible and visible, can I see a thumbs up on the live chat, please? So today's session will be FMGE Biochem Quiz Part 2. And in this session, I've chosen few high-yield MCQs and previous year MCQs based on frequently asked topics. And using those MCQs, I'll help you understand. Good evening, Med Psycho. Using those MCQs, I'll help you understand relevant facts and concepts. Okay, so that is about today's session. And before we start the session, let me tell you a few facts about Unacademy's plans. So we have a Med Scholar test which is scheduled for 21st May 2023, and the time will be between 10 a.m. and 1:30 p.m. and total number of questions asked will be 200, covering all 19 subjects. And if you attempt this test, you have a chance to win up to 100% scholarship. And it's not just about getting the scholarship. If you attempt this test, you will be able to understand where you stand at the national level, because you will be getting national level ranking. Okay, so do participate in this test. Good evening, Shafiq. Good evening, Anindam. Yeah. So that's about the Med Scholar test. And if you're an FMG aspirant, now we have a target FMG 2023 batch. And we have already set we have already set a mark by having 100% learners who qualified in Jan 2023 FMG exam. And this will be a high yield revision batch for FMG aspirants, and the duration of this course will be 3 months, and totally it covers 200 plus hours. And in this course, all 19 educators will be covering all previous year MCQs, frequently asked volatile topics, and most frequently and image based questions. And this course is available at the cost of 5,250, and if you use any of the educators code, you get additionally 5% off. If you want, you can use my code, which is Shanmugapriya. Okay, so that's all about Unacademy's plans. Now let's start discussing few PYQs. So the first MCQ for today evening is cytochrome P450 is associated with what? This is an FMG Jan 2023 MCQ. Cytochrome P450 is a hydroxylase. All hydroxylases are monooxygenases. Yeah, they are all monooxygenases which use NADPH. Okay, so what is the right answer here? Very good, Anindam. Very good, Rathor. Yes, the answer is NADPH. We know that there are so many uses of NADH. The most important use of NADH is that it enters into electron transport chain. It gives rise to ATP. But NADPH cannot enter into electron transport chain. It can never act as a source of ATP. In that case, what is the use of NADPH? This is being frequently asked. So the first and foremost use of NADPH is it is necessary for reductive biosynthesis of all the lipids. So fat synthesis, be it fatty acid synthesis or cholesterol synthesis or bile acid synthesis, all these lipid synthetic pathways will need NADPH. The second use of NADPH is it is necessary for regenerating glutathione, which is an important antioxidant mechanism for RBCs. So it's necessary as a coenzyme for glutathione reductase, which is necessary as an antioxidant mechanism for RBCs. Third use of NADPH is it is necessary for ribonucleotide reductase, which helps in the formation of deoxynucleotides. And the fourth use is it is necessary for cytochrome, and the fourth use is it is necessary for cytochrome P450 enzymes. Okay, so tell me, what are the uses of NADPH? It is necessary for fat synthesis. It is necessary as a coenzyme for glutathione reductase in RBCs. Ribonucleotide reductase helps in synthesizing deoxyribonucleotides, and for cytochrome P450 enzymes. Okay. Now, what are the sources of NADPH? Can anybody answer this, please? Yeah, what are the sources of NADPH? This is also frequently asked. 1 second. Yeah. So the first source of NADPH, or the major source of NADPH, is HMP shunt. And very good, Rathor. And apart from HMP shunt, cytoplasmic isocitrate dehydrogenase. The third one is malic enzyme, which converts malate to pyruvate. So these are the two frequently asked sets of facts. So what are the sources of NADPH? HMP shunt, cytoplasmic isocitrate dehydrogenase, and malic enzyme, which converts malate to pyruvate. Okay. Now the next MCQ is this. How many of you saw this MCQ? An image-based question which was asked in FMGE Jan 2023. What kind of inhibition does this graph depict? What do you think is the right answer? First two steps of HMP. Very good, Dhruv. So what is the right answer here? First tell me what is the graph that is shown here? Yes, most of you are right. Rajesh, this is not competitive inhibition. This is non-competitive inhibition. So how will you find out what type of inhibition is this? By looking at the plot. First tell me what is this plot? Do you see reciprocals on both x-axis and y-axis? Along x-axis you have 1 by substrate concentration. Along y-axis you have 1 by V. That is why we call this as double reciprocal plot. So tell me what is this plot called as? This is double reciprocal plot. This is also called as Lineweaver-Burk plot. Okay, Lineweaver-Burk plot, and this will help you in finding out what type of inhibition is this. Now, if you look at such a graph, point number 1 that you should check is which is the uninhibited graph and which is the inhibited graph. Do you see that this is marked as uninhibited? This is marked as inhibited. Now, what is the effect of inhibition? Effect of inhibition is on Vmax and on Km. Now, when the graph gets shifted above, when the curve gets shifted above, what is happening to 1 by Vmax? 1 by Vmax is high. If 1 by Vmax is high, Vmax is low. So, because of this inhibitor, one effect is Vmax is low. And do you see that both the uninhibited curve and the inhibited curve touches the x-axis at the same point, which means Km is normal. So if you look at the graph, you will know what happens to Vmax and what happens to Km. Can you tell me what has happened to Vmax here? Vmax is reduced and Km is normal. And whenever there is normal Km, write it as normal Km, it means it is non-competitive inhibition. Do you all understand this? If Km is normal Km, it is non-competitive inhibition. So the answer here is choice C. But I am going to fill up this tabular column. Okay, I am going to help you understand how to pick up the right answer whenever an image-based question is asked. Okay, so what are the types of inhibition about which you are frequently asked? The first type of inhibition is competitive inhibition. Second type is uncompetitive. This is not non-competitive. The second type is uncompetitive inhibition. The third type is mixed inhibition. And the fourth type is non-competitive inhibition. Okay, so what are the four types? Competitive, uncompetitive, mixed and non-competitive inhibition. So first about competitive inhibition, as the name indicates, here there is a competition between the substrate and the inhibitor to go and bind to the enzyme. Yeah, in competitive inhibition, there is a competition between substrate and inhibitor to go and bind to the enzyme. In that case, when you increase the substrate concentration, it overcomes the inhibition and the probability that the substrate goes and binds to the enzyme will be high. So, competitive inhibition will be overcome by increasing the substrate concentration. If you can overcome the inhibition, what happens to Vmax? Vmax will remain normal. All of you please remember, normal Vmax is observed in competitive inhibition. But to reach that Vmax, you have to increase the substrate concentration. So what happens to Km? Km is increased. Because what is Km? Km is the substrate concentration at half maximal velocity. Km is a substrate concentration at half maximal velocity. Because you have to increase the substrate concentration, Km is increased but Vmax is normal. Now about uncompetitive inhibition. For uncompetitive inhibition, you cannot overcome the inhibition. So Vmax is low. But you should also remember that in uncompetitive inhibition, there is parallel shift of both Vmax and Km. In the sense, Vmax is low and Km is also low. Do you understand this? In uncompetitive inhibition, both Km and Vmax are low. Okay. Now mixed inhibition, both the values get altered in the wrong direction. So in mixed inhibition, Vmax is low and Km is high. So what should you remember about mixed inhibition? Generally for an enzyme, if I ask you about an enzyme, I would say yes, this enzyme is good if I see that the Vmax is high and Km is low. But in the presence of a mixed inhibitor, both the values get altered in the wrong direction. So what happens to Vmax? Vmax is low and Km is high. And what did I tell you about non-competitive inhibition? Non-competitive inhibition, what is normal? Km is normal. So if Km is normal and Vmax is low, that is non-competitive inhibition. Is that clear? So how will you find out what kind of an inhibition it is? Can you quickly fill up this tabular column again? In the presence of competitive inhibition, you can overcome the inhibition. So Vmax is normal, but Km is high. Uncompetitive inhibition, I said parallel. So what do you mean by parallel shifting? Not only Vmax is low, Km is also low. Mixed inhibition, both get altered in the wrong direction. Km is high and Vmax is low. Non-competitive inhibition, NK, right? So what is normal? Km is normal, but Vmax is low. Okay, so that's all about types of inhibition. So tell me what is the right answer. Now look at this graph. Do you understand that this bottom line is an uninhibited line? The top one is in the presence of an inhibitor. Presence of an inhibitor has increased the Vmax. Increase the 1 by Vmax. So Vmax is low. Even in the presence of inhibitor, Km remains normal. If Km is normal, what is the right answer? It is non-competitive inhibition. Got it? A very simple one-liner. Tell me the right answer. Which of the following is cardioprotective? Cardioprotective fatty acid is omega-3 fatty acid. Yeah, have you heard of cervonic acid? What is cervonic acid? It is docosahexaenoic acid. Ecosa means 20, docosa means 22. So cervonic acid is DHA, docosahexaenoic acid, which has 22 carbon atoms, 6 double bonds, and it is of omega-3 type. Okay, 22 carbon atoms, 6 double bonds, it's of omega-3 type, and that is cardioprotective. Okay, so it's omega-3 fatty acids. Answer this. This is a June 2022 MCQ. A patient presented with tendon weakness, ataxia. There was history of 1 episode of unconsciousness. Which vitamin deficiency is the cause? The moment you see ataxia, what will you remember? Have you heard of GOVA? What does GOVA stand for? Global confusion, ophthalmoplegia and ataxia. Right? Global confusion. Rathore. Folic acid. Folic acid deficiency presents as what? Macrocytic anemia. Yes or no? Folate deficiency will present as macrocytic anemia because folate or tetrahydrofolate is necessary for purine and pyrimidine synthesis. And without purine and pyrimidine, replication will not be possible. Without replication, cells cannot divide. So cells keep growing, but they are not able to divide. So what will it cause? It will cause macrocytic anemia. Do you all understand this? So that will be the presentation of folic acid. It's not going to present with neurological manifestations. So whenever you see neurological manifestations, what should you think of first? First, you should look for B12. If you see B12, go for it. If you don't see B12, look for thiamine. Because for nerve metabolism, thiamine is necessary. So what is the answer here? The answer here is thiamine. Okay. Because don't you know that thiamine deficiency can present itself as acute thiamine deficiency or as chronic thiamine deficiency. And acute thiamine deficiency is nothing but Wernicke's encephalopathy. Chronic thiamine deficiency is nothing but Korsakoff syndrome. Do you all remember this? Yes, acute thiamine deficiency is Wernicke's encephalopathy. Chronic thiamine deficiency is Korsakoff syndrome. Wernicke's encephalopathy will present as GOVA. What does GOVA stand for? Global confusion, ophthalmoplegia and ataxia. And because you find ataxia here, what is the right answer? The right answer here is thiamine. And as one of you, med psycho, has mentioned it, thiamine deficiency can present as dry beriberi with neurological manifestations. Okay. Now, what will Korsakoff syndrome present with? When it is just acute thiamine deficiency, it is reversible, and here the patient presents only with confusion. But when it is Korsakoff syndrome, there is complete memory loss. So they present with retrograde and anterograde amnesia. Yeah, what do they present with? They present with retrograde and anterograde amnesia and with sensory agnosia. Okay, so answer here is thiamine. Answer please. This has been frequently asked in FMGE. So this is again in FMGE June 2022 MCQ. In fasting state, plasma glucose is maintained predominantly by what? In fasting state, plasma glucose is maintained by number 1, liver glycogenolysis. Okay, only when liver glycogenolysis happens, from glycogen of liver, glucose will be released. After which it is gluconeogenesis. So your body does not have any other magic but two pathways. So what are the two pathways which can maintain blood glucose? One is liver glycogenolysis, the other one is gluconeogenesis. Very good, Soumya. Answer is choice B. Okay. Glycolysis cannot maintain blood glucose. Glycolysis uses glucose. It reduces blood glucose level. Similarly, glycogenesis means glycogen synthesis. And for synthesizing glycogen, you will be using glucose. Okay. Yeah, starvation is not only gluconeogenesis. Very good, Dhruv Kumar. Both glycogenolysis and gluconeogenesis. Okay. This is another question which is related to the same concept. Again in FMGE and MCQ. A person gives blood sample for fasting plasma glucose estimation at 7 a.m. His last meal was a dinner at 8 p.m. the previous night. The major source of plasma glucose is. Did you all see this MCQ? Yeah. So what is the right answer? Yes. Very good. No, it's not ketone bodies. Ketone bodies do not synthesize glucose. Okay, Rato? Ketone bodies cannot synthesize glucose. Because when ketone bodies get metabolized, ketone body, for example, is acetoacetate. When it gets metabolized, it forms acetyl-CoA. And acetyl-CoA can never form glucose. Do you all understand this? Acetyl-CoA can never form glucose. So ketone bodies can never give rise to plasma glucose. So let's exclude choice D completely. So the right answer is liver glycogenolysis. Because I'll tell you what happens when you starve. Okay. So for the initial 2 to 2.5 hours after your previous meal. Suppose you had your breakfast at 8 p.m. Okay, let me assume that you all had your breakfast at 8 p.m. Till 10 to 10:30 p.m. your dietary glucose will maintain plasma glucose. After which contribution from dietary glucose decreases. But can you allow plasma glucose to decline? You should not. Because the principal cells of your body, namely neurons and RBCs, are dependent completely on glucose. So when you are starving, your primary aim will be to maintain plasma glucose. For that, the first pathway that gets stimulated is liver glycogenolysis. So please understand, glycogenolysis can happen in liver and in muscle, but only liver glycogenolysis can increase blood glucose, muscle glycogenolysis cannot. Because muscle does not have glucose 6-phosphatase enzyme. Right? Muscle does not have glucose 6-phosphatase enzyme. So liver glycogenolysis begins 2 to 2.5 hours after the previous meal, and it can maintain blood glucose only till 12 to 18 hours of starvation. So why am I restricting it to 12 to 18 hours? Because at that point all glycogen stored in liver will get used up. And then it is gluconeogenesis. And you will not be waiting for the last molecule of glycogen to get used up, and then you will not switch over to gluconeogenesis. There is always an overlap. So gluconeogenesis begins 6 hours after the previous meal. Okay, though it begins 6 hours after the previous meal, till 12 to 18 hours of starvation, what maintains plasma glucose predominantly? It is liver glycogenolysis. And because here the person has had 8 p.m. muscle, yeah, very good, Dhruv Kumar, yeah, right. Because the person has had dinner at 8 p.m. and then giving glucose sample at 7 a.m., it is 11 hours, right? This is 11 hours of starvation. Till 12 to 18 hours, which is the major source of plasma glucose, it is liver glycogenolysis. Okay, so what is the right answer here? The right answer here is B. So what are the facts that you have learned here? I want you to understand that ketone body can act as a fuel directly. Ketone body does not give rise to glucose. Okay, because acetyl-CoA can never give rise to glucose. Okay. Did you see this MCQ? A boy presents with voracious appetite and overall swelling. He is most likely suffering from Jan 2022. Is it marasmus or kwashiorkor or marasmic kwashiorkor or obesity? What do you think is the right answer? AP Rato says marasmus. Okay. Because there is voracious appetite, okay, protein energy malnutrition can present itself as marasmus or as kwashiorkor. And marasmus will present with voracious appetite. But marasmic children will be very thin. They will be very skinny. Only kwashiorkor children will present with overall swelling. Don't you all know that? Yeah. The moment you see swelling, it means there is protein deficiency. Only when there is protein deficiency, you can expect edema. So edema is a feature of kwashiorkor, but voracious appetite is a feature of marasmus. So I would prefer it to be marasmic kwashiorkor, which is a severe form of malnutrition. Okay. So let me tell you the differences between marasmus and kwashiorkor first, and then I will tell you what is marasmic kwashiorkor. So what is marasmus? Marasmus is entire calorie deficiency. The child or the infant has not had food at all. That is completely calorie deficiency. Okay. Whereas in kwashiorkor, the child is fed with something, but that is rich in carbohydrate. It does not have protein at all. So what is kwashiorkor? There is no calorie deficiency. The child is being fed with carbohydrate rich diet, and so there is only protein deficiency. Okay. Now age of presentation. Marasmus presents very early. It will be presenting in an infant. Whereas kwashiorkor presents from 6 months to 3 years. At this point, probably the child has got his own choice or her own choice of what he or she can have. So if there is no supervision from the parent, then the child will prefer to have carbohydrate rich diet. That is how I remember it. Okay. So between 6 months and 3 years, kwashiorkor is common. Now appetite, when there is complete calorie deficiency, what do you think about appetite? Marasmic children will have voracious appetite. Whereas in kwashiorkor, the child is fed but with carbohydrate rich diet. So will the child feel hungry? No. So there will be lack of appetite. Kwashiorkor, there is lack of appetite and the child will be irritable. Okay. Now edema is a feature of kwashiorkor wherein there is protein deficiency. Whenever there is protein deficiency, there is hypoalbuminemia, which will cause fluid shift from the circulation into the interstitium. So edema is a feature of kwashiorkor. Okay. Now fatty liver is a feature of kwashiorkor because in kwashiorkor there is protein deficiency and lymphatic drainage gets affected. And from the liver, fat comes out of the liver, gets into lymphatic. So lymphatic drainage getting affected is the reason for fatty liver. So if you remember these differences between marasmus and kwashiorkor, you'll be able to answer most of the questions. Okay. So tell me, what is marasmus? Marasmus is entire complete calorie deficiency. Kwashiorkor, no calorie deficiency, only protein deficiency in the diet. Marasmus presents early. Kwashiorkor between 6 months and 3 years. Marasmic children present with voracious appetite. Kwashiorkor, there is lack of appetite. There is edema in kwashiorkor. There is fatty liver in kwashiorkor. So what do you mean when you see, if you see a child presenting with voracious appetite but with edema, it means there is severe. There is a severe form of malnutrition, which is marasmic kwashiorkor, wherein there is not only protein deficiency, that has progressed further to cause calorie deficiency as well. And here the child's weight will be less than 60% of comparable weight. Okay, less than 60% with edema. Okay, because there is edema in kwashiorkor, the weight will be between 60 and 80% of normal weight. But in marasmic kwashiorkor, the weight will be less than 60% and with edema. That is when they present with both voracious appetite and with edema. Okay, so what is the right answer here? The right answer here is marasmic kwashiorkor. And there was another question on kwashiorkor and marasmus. that is sugar baby syndrome. What is sugar baby syndrome? Answer this please. Yes, kwashiorkor, poor prognosis. Sugar baby, a baby who feeds only on sugar, only carbohydrate rich diet. So that causes protein malnutrition, right? So that is kwashiorkor. Yes, sugar baby syndrome is kwashiorkor. The enzyme that is released in hypothalamus is, when I saw this MCQ in an FMGE paper, I was like astonished. Okay, so generally FMGE papers are easier when compared to NEET PG or INI-CET, but that was a good olden days story, right? That was a good olden days story. Now do you see a transition? Yeah, there is a huge or rapid transition in the way questions are asked in FMGE paper. I don't see much of a difference between what FMGE paper has and what NEET PG paper has, right? So there are so many case-based MCQs, there are so many applied MCQs, image-based MCQs, and this is one of the toughest MCQs that I've seen. Okay, so what is this? The enzyme that is released in hypothalamus is, very good mnemonics is right, med school mnemonics is right, it is hexokinase 4. Yeah, the enzyme that is released in hypothalamus is hexokinase 4. So we know there is one enzyme called as hexokinase, the other enzyme which is glucokinase. Both hexokinase and glucokinase convert glucose into glucose 6-phosphate with the help of one ATP. Okay, so we know about hexokinase and glucokinase. But what is interesting is hexokinase has got 4 isoforms, hexokinase 1, 2, 3 and 4. And here hexokinase 4 is glucokinase. Do you all understand this? Hexokinase 4 is nothing but glucokinase. Now what is the difference between hexokinase and glucokinase? Hexokinase, all these 3 types are present in all cells. Hexokinases are present in all cells. Whereas glucokinase is present in liver, pancreatic beta cells, and they are also released by hypothalamus and intestine. Okay, so glucokinase is present in liver, pancreatic beta cells, hypothalamus and intestine. So which is the enzyme that is released in hypothalamus? It is hexokinase type 4, which is nothing but glucokinase enzyme. Okay, so how many of you want to know about differences between hexokinase and glucokinase? In any exam, okay, in any exam when they say it is a PYQ, previous year question, what they do is they take the same topic but they twist the MCQ and ask. So when they can ask you this MCQ anytime, they'll ask you about differences between hexokinase and glucokinase. Biochemistry in 25 hours. Yeah, so biochem in 25 hours will be of use to you to form a strong foundation biochemistry. But if you want to learn about clinical biochemistry sessions, I would recommend that you watch live sessions as well, Shafiq. Okay. So I'm going to tell you the differences between hexokinase and glucokinase. Tell me what is the first difference? The first difference is location. Hexokinase is present in all cells, but glucokinase is present in liver. You can use that as a primary source, Shafiq. Yeah, but to add on to it, please watch all live sessions. Okay. So glucokinase is present in liver and pancreatic beta cells. Okay, apart from that, just now I told you it is also released by hypothalamus and intestine. That's the first difference. Now the second difference about Km and affinity. Before we discuss this, I would like you all to know that Km is inversely proportional to affinity. You all understand this? Km is inversely proportional to affinity. Now between hexokinase and glucokinase, glucokinase, which is present in liver and pancreatic beta cells, exhibits lower affinity for glucose or higher Km. Glucokinase exhibits lower affinity or higher Km. Is PYQ enough for FMG? I would have told you yes had you asked the same question like 2 to 3 years back. Okay, but now there are so many conceptual MCQs. So I would recommend all FMG aspirants to switch over from just looking at PYQs to start working out the entire subject in a comprehensive manner. Okay, try to learn the subject in a conceptual way. That way you will not only be able to clear FMG exam, you will also get ready for the next exam, right? Yeah, ultimately you'll have to get a good PG seat, for which you'll have to write either NEET or next. Okay, so do not just get satisfied by working on PYQs. Yeah, but at the same time, I want you all to definitely work on PYQs. Do not skip PYQs, but that alone will not be enough. Okay, you should have a conceptual understanding of all the subjects. Okay. So let me tell you few tips. Yeah, let me give you few tips for FMG aspirants. The tips would be: number one, write grant tests. Okay, write grant tests, as many grant tests as possible, irrespective of the level of preparation you are in. And when you write the grant test, don't worry about the mark that you get. Don't worry about the rank which you get. It is just for you to understand the level of preparation that you are in, and for you to understand what are the frequently asked topics. Right? You will have to know what are the frequently asked topics, what are the frequently asked MCQs, so that when you start reading the subject, you will know what to concentrate on, because it's not humanly possible for anybody to complete all the 19 subjects. Okay, so that should be a smart work, and for you to work smartly, you should know what are the frequently asked topics. That you will get an idea of if you start writing grant test. Okay, and it's not just about writing the grant test. Ion selective electrodes and other electrochemical techniques. This is necessary only for PGs, right? Are you a post-graduation student, Murli Krishna? I don't think this is necessary for a PG aspirant. Probably I will conduct a session for medical PGs, biochemistry PGs, where I can tell you about ion selective electrodes. But for now, coming back to what you need to do, as I told you, write as many grant tests as possible. And it's not just about writing the grant test, you will have to review the grant test. Okay, so when I say review grant test, if a paper has got 300 MCQs, if the paper that you write has got 300 MCQs, you will have to schedule grant tests in such a way that every 15 days you write a grant test. Okay, so day 1 and day 16 you're going to write one grant test each, and between those days you have 15 days, right? In those 15 days, divide these 300 MCQs. So 20 MCQs every day. Okay, so look at every one of those 20 MCQs on a day, and read all relevant facts and concepts. Okay, that way you will be in touch with all 19 subjects. Do you all understand this? Because generally what students say is, I read about biochemistry in the early period of my preparation. I now know nothing about biochemistry. So that should not be something which you say. Okay, you should be in touch with all 19 subjects throughout your preparation. That is possible only when you review your grant test. So every day you work out 20 MCQs that you wrote in the previous grant test. That way, if you work out grant test, you will see a progressive increase in the score. Okay, generally students say, I've written 10 grant tests, ma'am, my mark does not seem to rise. There is a plateau, my mark does not increase. Why do you think the mark does not increase? Because you have not reviewed the grant test. Only when you review the grant test, you will understand what is the pattern of mistake which you commit. Okay, you will understand which topic to concentrate on. You will understand how to read a particular topic, how to read a particular concept. Okay, so if you do this, then my assurance to you is you will definitely clear your FMG. So step number 1 is writing grant test. Step number 2 is not skipping even one PYQ. Yeah, FMG, the last 4-year question papers, which means totally 8 papers, you should be very thorough about. And apart from this, please get a conceptual understanding of all the subjects. So that way you'll start relishing the process of learning. Okay, so do not just memorize, learn everything conceptually. Okay, hope this helps. So I was telling about KMN affinity of glucokinase. Glucokinase enzyme exhibits lower affinity or higher Km. Whereas hexokinase exhibits higher affinity and lower Km. Okay. Now inhibition by glucose 6-phosphate. So hexokinase and glucokinase convert glucose into glucose 6-phosphate. So for both these enzymes, the product is glucose 6-phosphate, and most of the enzymes in your body get inhibited by the product, and that is applicable to hexokinase as well. Hexokinase is inhibited by its product, which is glucose 6-phosphate, whereas glucokinase is not inhibited by glucose 6-phosphate. Okay, so there are so many special things about glucokinase. Hexokinase is inhibited by its product glucose 6-phosphate. Glucokinase is not inhibited by glucose 6-phosphate. The last difference is induction by insulin. Glucokinase is inducible by insulin, whereas hexokinase is not. Okay, glucokinase is inducible by insulin, whereas hexokinase is not. So have you understood the differences between hexokinase and glucokinase? Have a look at this and repeat it along with me. Hexokinase is present in all cells. Glucokinase is present in liver, pancreatic beta cells, hypothalamus and intestine. Glucokinase exhibits lower affinity or higher Km. Glucokinase is not inhibited by its product, which is glucose 6-phosphate. Glucokinase is inducible by insulin. Okay. PG from Biochemistry. Okay, Murli Krishna. Probably I will upload a video on my YouTube channel. Okay, for ion selective electrodes. So this is also a PYQ. Tell me what is the right answer. A postmenopausal woman. Though it's a case-based MCQ, it's a very simple MCQ. A postmenopausal woman presents with pain in the first metatarsophalangeal joint following intake of alcohol. I think it was also mentioned as in a party. So alcohol precipitates what? Gout. Very good. Yes, alcohol precipitates gout. And you know, gout presents most probably in the big toe. Yeah, big toe joint pain is the most common presentation of gouty arthritis. So in gout, what is your aim? Your aim is to reduce uric acid. And I hope you all know that xanthine oxidase is the last enzyme which converts xanthine to uric acid. So which enzyme should be inhibited for you to reduce the uric acid level? Please clear your doubt on inhibitors of glycolysis. Definitely PPS. What is your doubt about inhibitors and glycolysis? I'll tell you now. Okay. So xanthine oxidase is inhibited by drugs which are used for treating gouty arthritis. Allopurinol. Right? Allopurinol inhibits xanthine oxidase and that's used in gout. So what is your doubt about inhibitors of glycolysis? So there are few chemical inhibitors of glycolysis which I'll tell you now. All of you memorize it along with me. So the first enzyme is glyceraldehyde 3-phosphate dehydrogenase. Okay, the first enzyme is glyceraldehyde 3-phosphate dehydrogenase, which is inhibited by iodoacetate. Please memorize it. Iodoacetate inhibits glyceraldehyde 3-phosphate dehydrogenase. And then phosphoglycerate kinase. Phosphoglycerate kinase ends with ATE. And that is inhibited by arsenate. Okay, that is inhibited by arsenate. And then enolase. Tell me the answer. Enolase is inhibited by what? Fluoride. And that is why you use a combination of sodium fluoride and potassium oxalate for plasma glucose estimation. Okay, so these are the glycolysis inhibitors. Iodoacetate PPS. What is your doubt about it? Iodoacetate is a chemical. Iodoacetate is a chemical which inhibits glyceraldehyde 3-phosphate dehydrogenase of glycolysis. Okay, arsenate inhibits phosphoglycerate kinase. Fluoride inhibits enolase. Does that clarify your doubt about inhibitors of glycolysis? Yeah, and apart from these chemical inhibitors of glycolysis, you should also remember that some products also inhibit glycolysis. For example, phosphofructokinase 1. So what is that? You know about phosphofructokinase 1? That's a rate limiting enzyme of glycolysis. And this rate limiting enzyme of glycolysis is inhibited by all its products. So what are the products? Citrate. Okay, citrate and ATP inhibit phosphofructokinase 1. Okay, citrate and ATP inhibit phosphofructokinase 1. Okay. So let's discuss the next MCQ. Peripheral conversion of T4 to T3 is done by what? Again, FMGE Jan 2023 MCQ. Peripheral conversion of T4 to T3, a very simple MCQ, right? It is done by deiodinase. Okay, so what are the other questions that can be asked about deiodinase? The first fact about deiodinase, it is selenium dependent. Do you all remember that? Deiodinase is dependent on selenium. So what are the other selenium dependent enzymes? One is deiodinase. Second one is glutathione peroxidase. Okay, glutathione peroxidase. The third one is thioredoxin reductase. Okay, thioredoxin reductase. So that we have learned two important facts. Peripheral conversion of T4 to T3 is done by deiodinase. Deiodinase is selenium dependent enzyme. Other selenium dependent enzymes are glutathione peroxidase, thioredoxin reductase. And deiodinases, we have D1, D2 and D3 deiodinases. Have you learnt about this in physiology and medicine? We have three types of deiodinases. D1, D2 and D3 deiodinases. D1 and D2 deiodinases are 5' deiodinases which convert T4 to T3. What we want, what is that you want? The active form of thyroid hormone is T3. But the most commonly secreted hormone from thyroid gland is T4. So T4 has to be converted to T3 for it to become the active form. That is done by D1 and D2 deiodinases, which are 5' deiodinases. Whereas D3 deiodinase is a 5 deiodinase which converts T4 to reverse T3. Okay, it converts T4 to reverse T3. Okay, so have you learnt about all these facts? So this is a very applied MCQ which I have not even seen in NEET PG papers. Okay, so try to answer this. A middle-aged patient presented with high anion gap metabolic acidosis and is diagnosed with defect of pyruvate dehydrogenase complex. Which of the following dietary advice would you prescribe? Who knows the answer? What is a dietary advice that you would prescribe for a person who has got PDH complex defect? Let me tell you the answer and then explain it to you. Okay, PDH complex defect, you should prescribe low carbohydrate diet. What should you prescribe? A low carbohydrate diet. Why? It is because what is the function of PDH complex? Pyruvate dehydrogenase complex converts pyruvate into acetyl-CoA. Can you all memorize this? Lactate dehydrogenase converts pyruvate to lactate. Pyruvate dehydrogenase converts pyruvate to acetyl-CoA. So from where do you get this pyruvate? You get this pyruvate from glucose. So glucose goes through glycolysis, gets converted to pyruvate, and then PDH complex converts pyruvate into acetyl-CoA. Then this acetyl-CoA will enter into citric acid cycle and acetyl-CoA will come out as carbon dioxide. This is how carbohydrates get oxidized. Now tell me what is expected when a person has got a defect of PDH complex. What will accumulate? Pyruvate will accumulate. When pyruvate accumulates, it gets converted to lactate. Right? Pyruvate can be either converted to acetyl-CoA, which is good for you because acetyl-CoA can get into citric acid cycle. Or pyruvate can be converted to lactate by lactate dehydrogenase. So when PDH complex is not active, all the pyruvate will be converted to lactate. Lactate is a lactic acid. So accumulation of a metabolic acid will cause increased anion gap metabolic acidosis. This is what is given in the question. Okay, they are asking you what is the diet plan that you would recommend. Your diet plan should be aimed at avoiding a source of pyruvate. How will you avoid the source of pyruvate? You are from first year, but happy to see that I can answer. Good PPS, very good. I am happy that you are interested from the first year. So which college are you from? PPS, are you from an Indian medical college or a foreign medical college? So if you don't want lactic acidosis, what should you do? You should avoid the source of pyruvate. How will you avoid the source of pyruvate? By avoiding glucose. How can you avoid glucose? By carbohydrate restricted diet. Okay, so now you know there should be a carbohydrate restricted diet. Now can it be choice A? Only carbohydrate intake henceforth. Will you recommend that? Definitely no. High carbohydrate, low fat intake? No. It should be low carbohydrate diet. Even after you know that it's going to be low carbohydrate diet, you have two more choices left. Is it going to be a high fat diet or high protein diet? I would say it's a high fat, low carb diet, which is a keto diet, ketogenic diet. Why not high protein, low carb diet? Because even protein, when you intake protein, proteins get digested to give amino acids, and many of the amino acids on metabolism give rise to glycolytic intermediates. Many of the amino acids on catabolism give rise to glycolytic intermediate. That will also cause pyruvate accumulation. That will also cause lactic acidosis. Whereas if you take a high fat diet, all fat will get oxidized. All fatty acids get oxidized to form acetyl-CoA. So this block will not be affected. Do you all understand this? Indian Medical College, KIMS, Bhubaneswar, Odisha. Very good PPS. Okay, so this is where the block is. So if you can give something after this, nothing happens, right? No defect happens. So tell me, what will you recommend for this person with PDH complex defect? So I want you to remember that PDH complex converts pyruvate to acetyl-CoA. You should suppress all substrate formation pathways and you should stimulate anything beyond this. Okay, so substrates can be reduced by low carbohydrate and high fat diet. Atkins diet is simple, Murali Krishna. Atkins diet is just low calorie diet. Okay, whereas keto diet is not just low calorie, it's not worried about the calorie at all. It is about high fat, low carb diet. I would say keto diet is zero carb, high fat diet. So all fatty acids will be oxidized to form acetyl-CoA, and all these acetyl-CoA will condense to form ketone bodies. That's why it's called as ketogenic diet. I will tell you how it works in the next class probably. But for now, Atkins diet is just a low calorie diet, whereas keto diet is high calorie, high fat, low carb diet. So answer this. This is also an FMGE Jan 2023 MCQ. Even seeing this MCQ, I was surprised. I would say sweetly surprised, because only when the quality of MCQs improve, quality of MCQ asked in the exam improves, the way students learn would differ, right? So only when questions like these are asked, you will start reading about all these concepts, and you will have to know clearly about molecular genetics and about genetics generally for you to become a good clinician. Okay, because now there is a rapid progression to precision medicine, rapid progression to personalized medicine. So you will not be able to understand precision medicine or personalized medicine if you don't have an understanding of genetics. Okay, so in liver, ApoB gene. What is the right answer? It's not gene splicing. Med school mnemonic is right. It is RNA editing. Okay, answer is RNA editing. So in liver, ApoB gene is completely translated to ApoB 100, and in intestine it is translated to ApoB 48. Which of the following mechanisms explains this? So answer is RNA editing. Let me explain you this. Okay, so watch this session carefully for another 5 minutes, not even 5, 2 minutes. Okay, then you will understand what it means. So first about ApoB 100 and about ApoB 48. ApoB 100 is an apoprotein of which lipoprotein? ApoB 100 is an apoprotein of VLDL. Yeah, ApoB 100 is an apoprotein of VLDL. And where is VLDL formed? VLDL is formed in hepatocyte. Whereas ApoB 48 is an apoprotein of chylomicron, which is formed in enterocyte. But interestingly, both these apoproteins are products of one common gene called as ApoB gene. So don't you think it's interesting to know that one gene, what is that gene? It is ApoB gene, can give rise to different protein products in different tissues. In enterocyte, it gives rise to ApoB 48. In hepatocyte, it gives rise to ApoB 100. So how is this difference possible? It is because, have a look at this, it's because of RNA editing. Let me tell you what is RNA editing. In both enterocyte and hepatocyte, this ApoB gene will be transcribed to form the same mRNA. Okay, the ApoB gene will be transcribed to form the same mRNA in both enterocytes and in hepatocytes. And this mRNA undergoes all post-transcriptional modifications to give rise to the same functional mRNA. And all these will happen in the nucleus. Now these functional mRNAs leave the nucleus and they reach the cytoplasm. And until they reach the cytoplasm, there is no difference between what happens in enterocyte and what happens in hepatocytes. But after they reach the enterocyte, there is a difference. Which topic? It's genetics PPS. So after they reach cytoplasm, there is a difference that happens in enterocyte. Because enterocytes have an enzyme by name cytidine deaminase. Please memorize it. What is the enzyme that is present in enterocyte? It is cytidine deaminase. And this enzyme acts on a codon CAA. So both in enterocyte and hepatocyte mRNA, there is a codon in between which is CAA. In enterocyte alone, there is a special enzyme called as cytidine deaminase, which acts on cytidine of a codon CAA to become UAA. So tell me, what is UAA? UAA is a stop codon. So in enterocyte, there is premature termination of protein synthesis. The moment stop codon is prematurely inserted, protein synthesis will be prematurely terminated. So enterocyte produces a truncated protein when compared to the whole protein. When compared to the whole protein that is synthesized in hepatocytes. So the truncated protein has got only 48% of the amino acids which are present in hepatocytes. So this truncated protein is called as ApoB48 and the whole protein will be called as ApoB100. This is called as RNA editing. Do you all understand what is RNA editing? Let me define RNA editing now. Now you will be able to understand it. So what is RNA editing? Here you edit, listen to this carefully, here you edit some of the nucleotide sequences of the fully formed mRNAs only in specific tissues. So what is that we do in RNA editing? In RNA editing you edit some of the nucleotide sequences in the fully formed mRNAs only in specific tissues, so that amino acid sequences of the proteins that you get out of them also get altered only in specific tissues. This tells you how can one common gene give rise to different protein products in different tissues, and that's called as RNA editing. So any doubt about RNA editing? If they ask you about RNA editing example, what will be your answer? Example is ApoB48 formation. If they ask you which enzyme is responsible for ApoB48 formation, your answer should be cytidine deaminase. Where is cytidine deaminase present? It is present in enterocyte. Okay. So what is the answer here? The answer here is RNA editing. So another FMGE Jan 2022 MCQ. Atrial natriuretic peptide acts through what? What is the right answer? Atrial natriuretic peptide and nitric oxide. Both these chemical messengers use a receptor, and this receptor has got guanylyl cyclase activity. Okay, atrial natriuretic peptide and nitric oxide receptors have guanylyl cyclase activity, which convert GTP to cyclic GMP. So it acts through what? It acts through cyclic GMP. Okay. But for completion's sake, let me tell you few chemical messengers which act through cyclic AMP. So those receptors which have adenylyl cyclase activity. Okay, adenylyl cyclase activity will form cyclic AMP, and this is present in all GS couple receptors. GSS stands for stimulating adenylyl cyclase, they form cyclic AMP. Example for GS couple receptors will be glucagon. So please don't forget this. First example for cyclic AMP dependent chemical messenger is glucagon receptors. Beta adrenergic receptors. You know, adrenergic receptors, you have alpha 1, alpha 2, beta 1, beta 2 and beta 3. And among these receptors, beta adrenergic receptors are coupled to GS. Okay. So beta adrenergic receptors, parathormone receptors, ACTH. Okay, parathermone ACTH. So all these are through cyclic AMP. Okay. Now IP3 and DAG are second messengers which are used by GQ couple receptors. So what are the GQ couple receptors? Alpha 1, beta adrenergic receptors are GS coupled. Alpha 1 is GQ coupled. And among muscarinic receptors, M1, M3. Okay, alpha 1, M1, M3 are GQ coupled. So these act through IP3 and DAG. Now how about tyrosine kinase? I hope all of you know this. Tyrosine kinase is insulin. Don't you know that? Yeah, insulin receptor has got intrinsic tyrosine kinase activity. Okay, so that's about chemical messengers and the way they act. So who can answer this question? A 20-year-old boy presents with severe mental retardation, mousy odor in body fluids and hypopigmentation. Patient has frequent episodes of seizures and aggressive behavior. What is your diagnosis? The major clue that is provided to you here is mousy odor, mental retardation. Med school mnemonic says it's MSUD. What did I tell you about maple syrup urine disease yesterday? I said maple syrup urine disease is caused by the defect of branch chain keto acid dehydrogenase enzyme. It presents with burnt sugar odor. Burnt sugar odor has got nothing to do with mousy odor. So whenever you see mousy odor, it is phenylketonuria. Okay, so what is the right answer here? The right answer here is phenylketonuria. So I'm going to help you memorize about all urine odors and diagnosis, as I say in every session, because I feel that these are major clues that will help you in choosing the right answer. Okay, so how to remember that mousy odor is a feature of phenylketonuria? We know that mouse and keyboard go hand in hand. Don't we know that? Mouse and keyboard go hand in hand. So mousy odor is a feature of phenylketonuria. Okay, and then fruity odor. Fruity odor is a feature of what? Diabetic ketoacidosis. After fruit, it's a vegetable. It is cabbage. Okay, cabbage odor is a feature of type 1 tyrosinemia. Okay, cabbage odor is a feature of type 1 tyrosinemia. To remember that, have this image in mind. What is that you see in this image? Do you see that tire is repurposed to grow cabbage? Yeah, tire is repurposed to grow cabbage. So cabbage odor is a feature of tire. What is tire? Type 1 tyrosinemia. Okay. After cabbage odor, it is boiled cabbage odor. So boiled cabbage odor is a feature of hypermethionemia. Okay, it's a feature of hypermethionemia. How to remember this? Cabbage odor by itself is not that great. Boiled cabbage odor is too much to handle, right? Boiled cabbage odor is too much to handle. Too much is hyper, right? Too much is hyper. So boiled cabbage odor is a feature of hypermethionemia. After this, there is something else related to methionine malabsorption syndrome. Methionine malabsorption syndrome is otherwise called as Osthaus syndrome. So what is an Osthaus? Do you see that image here? What do you see in the image? Yeah, these are Osthauses wherein hops flour will be dried. In these Osthauses in European countries, hops flour will be dried to add flavor to beer. Okay, so Osthaus odor or beer odor. We also call it as beer baby syndrome. Okay, Osthaus syndrome or beer baby syndrome is nothing but methionine malabsorption syndrome. Okay, and then swimming pool odor. This is a house. Remember a house with a pool. Okay, swimming pool odor is a feature of Hawkinsinuria. How to remember that swimming pool odor is a feature of Hawkinsinuria? Do you see a hawk flying above the pool? Yeah, hawk flying above the pool. So Hawkinsinuria is a feature of, no, Hawkinsinuria is characterized by swimming pool odor. Okay, so after swimming pool odor, it is sweaty feet odor. And sweaty feet odor is a feature of isobaric acidemia. Okay, so have a look at this image. Do you see that feet are kept on the ice, right? Feet are kept on the ice. So sweaty feet odor is a feature of ice, isovaleric acidemia. Okay. And after sweaty feet odor, you can remember burnt sugar odor. What did I tell you about burnt sugar odor? It is maple syrup urine disease. And then we have fish odor syndrome. Okay, the sweat or any fluid, any body fluid will smell of fish. So it's called as fish odor syndrome, and that is caused by a defect of flavin dependent enzyme. Okay, flavin dependent enzyme. It is trimethylaminiuria. Fish odor syndrome is otherwise called as trimethylaminiuria. Okay, it is caused by the defect of flavin dependent monooxygenase. And then tomcat urine odor. Okay, tomcat urine. Cat, do you see CA? Yeah, so tomcat urine odor is a feature of multiple carboxylase deficiency. Tomcat urine odor is a feature of multiple carboxylase deficiency. So these are the odors that can be used as clues for you to make a diagnosis. So can we fill up this tabular column? Yeah, I want all of you to keep the chat box active, please. So what is the first urine odor I told you about? The first one is mousy odor, which is a feature of phenylketonuria caused by the defect of phenylalanine hydroxylase. And then fruity odor is a feature of diabetic ketoacidosis. After fruit, it's a vegetable. Cabbage odor. Cabbage is grown in a tire, right? So cabbage odor is a feature of type 1 tyrosinemia. And then boiled cabbage odor is a feature of hypermethionemia. After hypermethionemia, it is methionine malabsorption syndrome. Right, methionine malabsorption syndrome. I said this is also called as Osthaus syndrome or beer baby syndrome. So here the child smells of Osthaus or smells of beer. Okay, so that's about Osthaus. And after house, it is a swimming pool, right? So swimming pool odor is a feature of, what did I tell you? Swimming pool, Hawkinsonuria. Okay, and then sweaty feet odor. Sweaty feet odor is a feature of isovaleric acidemia. And then tomcat urine odor. Tomcat has got CA. It is caused by the defect of multiple carboxylase enzyme. Okay, so that's all about urine odor and disorders. So what is the right answer here? Mousy odor is untreated phenylketonuria. Okay, so I hope this session helped you. I will meet you with another live YouTube session probably in the next week. Okay, so until I meet you, please don't forget to revise all these facts that we have discussed so far. And also do not skip writing grant tests. Do not skip working on PYQs, but at the same time learn all subjects conceptually. Yeah, thank you. Good night.